Mike Gibson and Greg Stone coming to you virtually for TCT 2020. And Greg, we're talking about a trial I wanted to do that you did, which is it's the Prospect Absorb trial. Now, we usually treat the Titus blockage or the thrombotic blockage, but you looked at what happens if you intervene on the vulnerable plaques. Fascinating. Tell us what you found, Greg.
Well, Mike, you're absolutely right, and but there's an increasing recognition that just ischemic lesions don't explain all the events that are happening, especially in patients with acute coronary syndromes and diabetics. And
Right.
we learned from the first Prospect study that you can identify non-flow limiting plaques that place those lesions and patients therefore at risk for future adverse cardiovascular events. And in Prospect 1, they were really plaques that had large plaque burden, that were thin cap fibroatheromas according to virtual histology and ultrasound technique, and that also had a small minimal luminal area, despite having a diameter stenosis of 32% by angiography. So virtual histology, of course, never really caught on because it's difficult to do, it's difficult to interpret. So in Prospect 2, which I know you're covering separately, we assessed integrated NIRS IVUS catheter, that is near infrared spectroscopy in IVUS, to be able to detect vulnerable plaque. And as you saw from that study, we were able to successfully, looking at lipid-rich plaques as well as those with high plaque burden, detect vulnerable plaque. So the question is, what do you do about these things once you identify them? And of course, it makes sense to use potent medical therapy, high-dose statins, and if you can't get control there, perhaps PCSK9 inhibitors. But all the patients in our studies are already on all that, and they're still having a high incidence of events. So what we did was, as a pilot trial to inform a large-scale randomized trial, we did a small randomized trial within Prospect 2 of vulnerable plaques defined as those with a high plaque burden, which was a validated finding from Prospect 1. And we randomized those lesions to get either an bioresorbable vascular scaffold versus just maximal medical therapy alone. And 98% of the patients were on statins, 85 to 90% were on a high dose of atorvastatin or rosuvastatin. And so they were really on, DAPT with ticagrelor mostly for 12 months. So they're really on potent therapy. And we randomized 192 such lesions. And the hypothesis was in this pilot, could we safely enlarge the lumen? Okay, so that's what we were powered to show. We weren't powered for clinical effectiveness or even clinical safety. That would require a much larger trial. But in a couple hundred patients, we wanted to see if we could safely enlarge the lumen and change the morphology of the so-called vulnerable plaque by putting on the scaffold, therefore creating a neocap on top of the scaffold. And we found that we were able to safely enlarge the lumen. By treating these lesions with bioresorbable scaffolds, we brought them all back at 25 months for follow-up angiography. And we found out that we basically doubled the lumen size by treating with the bioresorbable scaffold from about 3 millimeters squared at baseline to approximately 6 millimeters squared at follow-up. In addition, we did create a neocap on top of the scaffold of about 210 microns. So, IVUS does not have the resolution to see if these were thin caps or not, but they were bulky plaques, about 75% plaque burden. They were lipid-rich plaques. They were about 33% lipid by the NIRS spectroscopy. And so we put the scaffold on safely. We created a thicker cap. And while we weren't powered for clinical events, it was very interesting when we looked at our predefined MACE endpoint, which was a lesion-specific endpoint adjudicated blindly. The lesions that were treated with medical therapy had about a 10% adverse MACE rate at 4 years, whereas the lesions that were treated with the BVS had a 4% MACE rate. So that was about a 60% reduction with a p-value of 0.12. Again, not powered for clinical efficacy, but very suggestive of a 60% reduction in major adverse events. Now, most of those major adverse events were rapid accelerating angina without myocardial infarction, but with rapid lesion progression. So because these patients were on high-dose statins and DAPT, et cetera, when they would have a thrombotic event, their plaque burden would double. The stenosis would go from an average of around 40% to 80%. It would cause accelerating severe angina, but their medical therapy kept the vessels open. But they all had to come in, of course, for a repeat procedure. So those are the main findings.
You mentioned the clinical events. Did you do QCA or some quantitative measure of the cross-sectional area? At follow-up, was it bigger with the scaffolding?
Well, we didn't do QCA for. We didn't do QCA quantity. We did QCA, of course, at baseline and follow-up, and at QCA, but we didn't do it in a cross-sectional, geometric determination. We just used the standard minimal luminal diameter and diameter stenosis. And the diameter stenosis went from about 41% at baseline to about 71% by follow-up QCA at the time of the event. So these were severe stenoses.
Sure. But in general, were the MLDs in the scaffold group bigger than the MLDs in the control arm?
Yes, they were much larger. I can give you the numbers if you want to wait a second, but they were much larger. They were doubled.
Oh, really? Wow. So the lumens were bigger.
Oh, the lumens were bigger. By imaging, the lumens were bigger. By QCA, they were also bigger too. Both the MLD was bigger, the diameter stenosis was lower, and interestingly, the angiographic restenosis rate of the BVS-treated lesions was 4.7%, and of the other lesions, the medical therapy-treated lesions, a diameter stenosis of greater than or equal to 50% was present in about 15% of the lesions, which was a statistically significant difference.
Wow. Okay, so a difference in disease progression.
Very much.
And a trend towards a difference in clinical events. Greg, did vulnerable, when you look at necrotic core, Plaques has shown us that the necrotic core was related to adverse outcomes. Did you look at necrotic core and the role that it played? I mean, did that play a role here?
Yeah, well, in the main Prospect 2 study, and I presume you're talking to David Erlangen, he'll go over those results in detail. But in the main Prospect 2 study, the necrotic core, in this case, is measured by the near-infrared spectroscopy maximum lipid core burden index over 4 millimeters, was a powerful independent predictor of MACE events, both at the lesion level and the patient level.
Similar to what Patrick had found earlier. So did that play, was there a positive interaction term kind of there? If you had a necrotic core at baseline, were your results even more impressive in terms of clinical event reduction?
Right. Well, the more of the high-risk characteristics that you happen to have in the lesions, then yes, the higher the event rate in the medical therapy arm and the higher the absolute event rate reduction in the treatment arm, although the relative reduction was similar, whether you had 0, 1, 2, or 3 high-risk plaque characteristics.
I see. Well, I was just wondering if, this would really be a benefit, particularly if you had those high-risk characteristics. Sounds like it was fairly homogeneous benefit.
Well, we do. And I think that's true. When you looked at the main Prospect 2 findings, if you had a plaque burden greater than 70% and a lipid core burden index of greater than 325, it's the upper quarter of them, then those lesions had a 7% event rate. If you had neither of those factors, those lesions had a 0.2% event rate. This is at 4 years. And if you had one of them, then it was a 1 to 2% event rate. So it is almost an exponential, increase when you have multiple of the high-risk factors.
Now, by the way, there's a patient attached to that, vulnerable lesion. Were there any patient-based risk factors that help determine who might benefit from this?
Really, the only patient-based risk factors in the present study was insulin-treated diabetes. In the first prospect study, it was insulin-treated diabetes and prior PCI. The prior PCI was not as potent in this data set, but insulin-treated diabetes is a major risk factor.
But that kind of makes sense clinically, right?
Yeah.
So Greg, this is very, very provocative. Are you going to be able to talk Abbott into following up with a larger study? I mean,
well, either Abbott or the Medtronic, Boston Scientific, the stent industry in general. I mean, I think it's really time to, now that we've got this pilot study showing even with the first generation BVS scaffold, we could safely treat these lesions. I think that probably metallic DES or a second generation scaffold would do even better.
Right. Well,
So
that's what I'm saying.
yeah.
Do we wait on a second generation scaffold? Do you think it would apply to other DES? I mean,
I do. I do. I think that we use the scaffold here because there had been a fair amount of work done by Patrick and others showing that the scaffold would create that nice neocap. It also would equalize wall stress across the lesion, and its non-permanence is just attractive if you're thinking of long-term treatment of vulnerable plaque. But there's been a lot of work done as well with metallic drug-eluting stents, and they really do the same thing. They create a neocap. The thinner metallic DES may be a slightly thinner neocap, but it would still be at least 100 microns, which is plenty. With 65 microns being a TICFA. So I think these results support a randomized trial, even with metallic drug-eluting stents.
Said like a true trialist. I actually think this is really, really, really cool stuff, Greg. So I do hope you're able to talk someone into doing it. And I think this is actually very, very, very fascinating. Congratulations.
Well, thanks, Mike. Appreciate it.
And thanks to all of you for, I think, listening to one of the more interesting presentations I've heard in a long time. Thanks for joining us here virtually for TCT 2020.